An unusual and fatal epidemic set in and plagued Geneva, Switzerland between February and April 1805. The outbreak began in a suspicious and scary manner, a very small distance from the city in a dirty quarter habituated by poor people and others vulnerable to the development of all contagious diseases. The distinctive and lethal nature of the disease startled the region's physicians because its symptoms distinguished it from all the other fevers that presented to physicians who had exercised their art in their cities for more than 30 years. This account was written by Dr. Gaspard Vissot and is considered to be the very first documentation of the dreaded disease known as cerebrospinal meningitis. And I cited this quotation from the book by Margaret and Dennis O'Leary titled The Texas Meningitis Epidemic 1911 to 1913. Hello, I'm Ibrahim Imam and welcome to this episode of the Neurology Lounge podcast titled Conflagration, the Firestorm of Meningitis. Meningitis is simply inflammation of the meninges covering the brain. But what an awful disease it is. Indeed, the O'Learys wrote that cerebrospinal meningitis was one of the most malignant, rapacious, non-discriminating, unpredictable, and difficult to control of all the contagious disease epidemics afflicting humans. The type of meningitis we have been describing so far, that which occurs in epidemics, is classically associated with the bacterium called Neisseria meningitidis. But almost all organisms, from bacteria and viruses to fungi and parasites, can cause meningitis if they can find their way into the skull. However, the most frequent bugs to do so are Streptococcus pneumonia, Haemophilus influenza, and Listeria monocytogenes. Just as an aside, meningitis does not have to rage as an epidemic. And meningitis does not have to be the result of an infection by microorganisms. For example, it can be caused by medications like non-steroidal anti-inflammatory drugs called NSAIDs, intravenous immunoglobulin or IVIG, vaccines, monoclonal antibodies, carbamazepine, lamotrigine, and sulfasalazine. Similarly, meningitis can be the manifestation of several autoimmune diseases like systemic lupus erythematosus or SLE, Sjogren's syndrome, rheumatoid arthritis, Kawasaki disease, Behçet syndrome, and Vogt-Koyanagi-Harada disease. One to check up. With these asides out of the way, let us go back to infectious meningitis and how it manifests. The O'Learys graphically portrayed the cardinal manifestations of meningitis, describing how it appears suddenly as a severe prostration with a violent headache, stiffness of the spine, and particularly in children with convulsions. And a uniquely distinctive feature of severe cases of Neisseria meningitidis meningitis is what they refer to as an eruption of violet spots upon the body. In fatal cases, they further added, the course was extremely rapid, lasting only 12 hours in some cases. The clinical picture of meningitis has not changed much since these early depictions. Apart from fever, neck stiffness, convulsions, and a skin rash in meningococcal forms, meningitis also presents with altered consciousness and can lead to coma. And on clinical examination, the cardinal features of meningitis are neck stiffness, also called meningismus, papilledema or a swollen optic nerve, paralysis of cranial nerves, focal limb weakness, and positive Koenig's, Brudzinski's, and jolt accentuation signs. 3 for the medics to check up. Meningitis also leads to disastrous complications such as cerebral vein thrombosis, brain abscess, subdural empyema or pus collections around the brain, hydrocephalus or raised pressure in the brain, and stroke arising from spasm of blood vessels. Let us illustrate the havoc meningitis wreaks with a contemporary lived experience of this horrible disease. And this is the account of Kieran as narrated by his mother Nicola Jane in her book titled Meningitis Me, Living with the After Effects. Kieran's illness started 4 weeks before he was diagnosed with meningitis, and it was all set off with a mundane runny nose and a cough. His mother wrote that he then became tired, achy and feverish, and complained of headaches and flu-like symptoms, and that he spent the day sleeping. Then one morning, she said, Kieran woke up crying and saying he felt sick, and then he vomited all over his bedroom floor and was complaining about the light hurting his eyes. However, when they took Kieran to the hospital, he was diagnosed with gastroenteritis and sent back home. Thereafter, he became confused and started experiencing odd dreams and running a temperature higher than 100 degrees Fahrenheit. The following morning, again, Kieran woke up screaming, saying that his head hurt. His mother wrote that he was gripping the headboard of my bed and lifting himself, twisting his body like he had suddenly become possessed. His parents took him back to the hospital emergency department, naturally, and his mother recalled this when she said, I struggled to carry my lifeless child into the hospital. She said, Kieran's legs were stiff. It was awkward to carry him, and he cried out in pain whenever I tried to get him to walk. She then said he started behaving oddly. 1 minute he'd be crying and unsure of where he was and who we were, and the next he was sitting up and asking if he could play on my phone. He was eventually transferred to the intensive care unit as the doctors found out that there was swelling on his brain. On the ICU, his mother said he was acting crazy, shouting, screaming, and telling people we were trying to kill him and that he did not know who she was. Kieran was eventually diagnosed with pneumococcal meningitis caused by Streptococcus pneumonia. Because he was a child, Kieran was vulnerable to meningitis because his immune system was not yet robust enough to fight the bacterium that had invaded his body. Other causes of immune compromise, such as diabetes and alcoholism, also increase the vulnerability to developing meningitis, as do the presence of infections elsewhere in the body, from otitis media and sinusitis to pneumonia and endocarditis. Meningitis is also likely to develop when there is an acquired access to the brain, such as following head injury, brain surgery, or cerebrospinal fluid leak. And meningitis can occur repeatedly in those born with a break in the back of the base of the skull called a fossa navicularis. Meningitis is, however, by no means a disease restricted to children or those who are immune or anatomically compromised. And this is graphically portrayed by Quasheta Smith-Triplett in her illness memoir titled My Life Surviving Meningitis. Smith-Triplett was 16 years old in 2005 when she woke up one morning in excruciating pain, unlike anything I had ever felt before. She wrote that my head throbbed worse than any migraine I had known, and that the pain was intense, sharp, and all-consuming. She said, I tried to sit up, but the pounding in my head only intensified. And when she opened her eyes, she said the light hit them like a knife, and even the slightest bit of light felt unbearable. She wrote that all she could focus on was the relentless pain in her head, which she said felt as though someone was hitting me with a hammer over and over again. And on the bus to school, she said the noise hit me like a ton of bricks. It was so loud that I wanted to scream for everyone to, and you can insert a swear word here. And in school, she described how her vision became blurry and how everything around me felt distant, like I was moving through a fog. It was the school nurse who raised the alarm when she recorded her temperature to be dangerously high at 104.1 degrees Fahrenheit. Just like Kieran, Smith-Triplett was also given the wrong diagnosis at first. She said, the doctor sent me home with antibiotics, diagnosing me with the flu. It is disheartening that she stayed at home for a further 2 weeks, progressively getting worse. And by the time she was taken back to hospital after this delay, she said, I was barely hanging on. I was slipping in and out of consciousness. The hallucinations were taking hold, twisting my mind and making everything feel surreal. The severity of her illness was such that she was in coma for almost a month, during which she experienced vivid, surreal dreams, which she said blended reality with a kind of dreamlike haze. Smith-Triplett's recovery was slow and emotionally turbulent, especially as meningitis sadly left her permanently blind. For an account of meningitis that is not caused by bacteria, let us take a look at the illness memoir of Ignazio Girardi titled The Consultant, a Meningitis Experience. Girardi wrote of how his illness developed most surreptitiously with visual blurring when he was driving. He said, I closed my eyes repeatedly, waiting for that to end, and after a few minutes, maybe 10-15 minutes, my eyesight normalized. But the symptom kept recurring. Girardi was describing what are called technically visual obscurations, intermittent blurring of vision that develops because the pressure in the skull is high, something technically called intracranial hypertension. It is telling that all the conventional tests Girardi underwent failed to identify the cause of his illness. This was the case until months later when a neurosurgeon performed a brain biopsy. And the disease he was eventually diagnosed with was fungal meningitis. Girardi's case illustrates the chronicity, which is how long it can go on, and the severity of fungal meningitis. He required hospitalization for 6 weeks, during which he was on intravenous antifungal treatment. And even after this treatment, Girardi struggled for several months with memory impairment, one of the consequences of meningitis. This was catastrophic for Girardi, as it made it difficult for him to return to his work as an engineer or to even hold on to the menial jobs he attempted, from sales to taxi driving. The most notorious cause of fungal meningitis is that caused by Cryptococcus neoformans, a fungus that seems to favor the nervous system. As was the case with Girardi, Cryptococcus neoformans causes a subacute, that is a slow meningoencephalitis, typically in people who are immunocompromised, such as those with AIDS, those with blood cancers, or those on organ replacement immunosuppressant medications. Before moving on to the investigations and treatments of meningitis, a word here about viral meningitis. The commonest viruses to cause meningitis are the so-called enteroviruses, which come from the tummy, and these account for 80% of adult cases, with echovirus 30 alone accounting for more than 50% of cases. Herpes simplex and varicella zoster viruses come a distant second and third. To investigate suspected cases of meningitis, doctors would look for bugs circulating in the blood by taking blood cultures. But more importantly, they will search for the bugs in the spinal fluid by performing a spinal tap or lumbar puncture, called LP for short. The importance of spinal fluid analysis in the management of meningitis cannot be stressed enough. CSF analysis gives an early clue to the presence and to the type of meningitis by the number and types of white blood cells that are seen. In bacterial meningitis, neutrophils predominate initially with cell counts as high as 5,000. You should normally not see more than 5 cells. The protein count is also increased to various levels depending on the cause of meningitis, typically between 0.4 and 0.8 grams per DL with viruses, 0.5 to 2 grams per DL in bacterial meningitis, and up to 3 grams per DL in meningitis caused by tuberculosis. Another clue to meningitis is a reduced glucose level in the spinal fluid relative to the blood, the so-called plasma glucose ratio. The results of spinal fluid culture follow a few days later, and these confirm the organism causing the meningitis. And beyond culture, the polymerase chain reaction, or PCR, can help to identify viruses. Doctors will, however, not wait for the results of these blood and CSF culture tests before they start treatment empirically with antibiotics. And the antibiotics of choice are the so-called third-generation cephalosporins, such as ceftriaxone and cefotaxime. Depending on the suspected cause and the characteristic of the patient, these may be combined with other antibiotics. For example, amoxicillin or ampicillin and cotrimoxazole are added when the patient is older than 60 years or if the patient is immunocompromised. Amoxicillin or ampicillin are also added when Listeria meningitis is suspected, and this is quite often in young children and in pregnant women. For those who are resistant to the penicillins, vancomycin and rifampicin are considered as optional antibiotics. The duration of antibiotic treatment also varies depending on the cause of meningitis, being about 7 days for Neisseria meningitidis, up to 14 days for Haemophilus influenza and for Streptococcus pneumonia, and 21 days for Listeria meningitis. In addition to antibiotics, doctors also administer the steroid called dexamethasone with or shortly before the first dose of antibiotic. This is often required with meningitis caused by Streptococcus pneumonia or Haemophilus influenzae, because these are more likely to lead to an increase in the intracranial pressure. Doctors also report all suspected cases of meningococcal and Haemophilus influenza meningitis to the public health authorities. Preventative treatment is also indicated for contacts of those who have meningococcal meningitis, and the treatment options here are rifampicin, ciprofloxacin, ceftriaxone, amoxicillin, and phenoxymethyl penicillin. Vaccination with the 4C-Men-B vaccine is also invaluable in preventing meningococcal meningitis in infants. And of course, routine childhood immunization is critical to preventing meningitis from such organisms as mumps, measles, and rabies. To explore meningitis further, I will be speaking to Janet Gilsdorf, pediatric infectious disease specialist and author of the book titled Continually Raving. And this will be in the next episode of the Neurology Lounge podcast. Thank you very much for listening or watching the podcast. Do click on the like button, and why not subscribe to the YouTube or Spotify channels to make sure you do not miss the next episode of the podcast. And whilst waiting for that, why not browse my website called Neuro Checklist, and why not check out my book called Surfing the Brain for more light touch neurology. Thank you very much, and do catch up with me when I'm speaking to Janet Gilsdorf in the next session of this podcast. Thank you very much.